Good afternoon, everyone. I would like to thank Nestle for the opportunity to speak in this webinar. First, I do have a few disclosures as shown on the slide. I'd like also to acknowledge the fabulous team of current trainees and staff in my lab who have contributed to the work I will be sharing today. Dysphagia is thought to affect more than 600 million people worldwide and has a reported prevalence of at least 20% in stroke survivors. Oropharyngeal dysphagia involves two primary functional problems that are illustrated in this video fluoroscopy. These include impaired swallowing safety with penetration or aspiration of material into the airway, and impaired swallowing efficiency where poor bolus clearance results in residue remaining behind in the pharynx. In 2002, Dr. Joanne Robbins and colleagues reported that the use of thickened liquids had become one of the most frequently used interventions for dysphagia, and this remains true today. However, the widespread use of thickened liquids and also of texture-modified foods is not without controversy. A couple of years ago, the Washington Post carried this story written by two medical residents who characterized the use of thickened liquids as a fate worse than death. There have also been several publications in medical journals recently that raise questions about the widespread use or perhaps overuse of thickened liquids and texture-modified diets, such as this 2018 article by Irish geriatrician Dr. Sean O'Keefe, or this 2019 article led by American hospitalist Dr. William Lippert, or this recent opinion article by Scottish speech and language therapist Tracy Lazenby Patterson. In all three articles, concerns are raised about the evidence base supporting the use of texture modification, particularly with respect to its effectiveness for preventing aspiration pneumonia in patients with chronic conditions involving dysphagia. I have been asked to comment on the current state of evidence behind this practice, and I'd like to tackle 5 key questions in the time that we have together. First, I will share with you evidence regarding the impact of thickened liquids on aspiration. Second, we will look at the longer-term impact of thickened liquids on pneumonia in people with dysphagia. Next, I will discuss the risk that thickened liquids may lead to increased pharyngeal residue. Fourth, I'd like to briefly discuss the effectiveness of alternatives to using thickened liquids. And finally, I will propose best practice recommendations regarding texture modifications for people with dysphagia. Throughout this talk, I will be referring to penetration and aspiration, meaning the entry of material into the larynx and the lower airway during swallowing. This slide shows you the 8-point penetration aspiration scale, or the PASS, that has become the standard scale for describing the severity of airway invasion events during swallowing. The scale can be broken down into different levels, and I've used traffic light color coding to illustrate our clinical understanding of the risk or severity of these levels. When the scale was originally published, Rosenbeck and colleagues considered a score of 1 to be normal. Scores of 2 to 5 were labeled as penetration, capturing situations where material entered the laryngeal vestibule and traveled as far down as, but not below, the true vocal folds. Scores of 6 and higher were labeled as aspiration, reflecting material falling below the true vocal folds. As you may know, for each level of depth on the scale, there are 2 possible scores, with the lower numbered score indicating that the material traveled that far but was then ejected, either completely out of the airway or to a higher location in the larynx, and the higher numbered score indicating that the material remained there without ejection. In the years since the scale was developed, it has been shown that scores of 2, where material enters the laryngeal vestibule but is then ejected, do occur in some healthy people, and this score is therefore no longer considered abnormal. For the purposes of our discussion today, it's helpful to step back from the detailed scores in the scale and to discuss swallowing safety in a binary fashion as either safe or unsafe, and I'm going to consider all scores of 3 and higher to be unsafe. The other thing that will come up repeatedly in this talk are terms describing the consistencies of foods or drinks used in dysphagia management. Here I'm going to use the terminology established by IDSI, the International Dysphagia Diet Standardization Initiative, which is in the process of being implemented worldwide. Where relevant, I will try to mention terms that were historically used for these same consistencies in the UK to explain the mapping. So let's get started by discussing evidence regarding the impact of thickened liquids on swallowing safety. The most commonly cited study of this question was led by Drs. Jerry Logeman and Joanne Robbins between 1998 and 2008 and is known colloquially as Protocol 201. As you can see from the title of this paper, they chose to explore the effectiveness of interventions, including thickened liquids, in people with dementia or Parkinson's disease. And this is a very interesting choice for two reasons. First, this population represents one where there was extremely widespread use of thickened liquids in the residential care sector. And second, in contrast to individuals with dysphagia following stroke, this study population is one in which dysphagia is expected to be chronic or even to deteriorate over time, such that spontaneous recovery would not represent a confounding factor when looking at outcomes. Logeman and Robbins included two experiments in their study, and the first of those experiments is shown on this slide. Here, potentially eligible participants underwent a baseline video fluoroscopy in which they swallowed up to 6 boluses of thin liquid barium. The first 3 were 3 milliliter boluses served by spoon, and those were followed by sips from a cup. Participants qualified to continue into the study by showing aspiration on at least one of those initial thin liquid boluses. And for those who continued, a random order of interventions was assigned, and they replicated the same protocol of 3 milliliter spoons of barium, followed by 3 sips from a cup for each intervention. Those interventions included thin liquids swallowed with the chin tucked down toward the chest, a thickened liquid that was called nectar-like, which would translate to a level 2 mildly thick liquid on the IDSI framework, and also to a syrup consistency using your old UK terminology, and a very thick liquid that was called honey-like, which was actually sufficiently thick to translate to the level 4 extremely thick range on the IDSI framework, or to a custard or pudding consistency using old UK terminology. The question that was asked was whether each participant's swallowing safety improved on each of those tasks. And the results of that first experiment are shown here on the slide. 51% of the participants responded well, showing no aspiration on at least one of those 3 interventions. However, 49% of the participants failed to respond and continued to aspirate on all 3 interventions, such that none of them was effective. And so in this group of more than 700 older adults with dementia or Parkinson's disease, we are left with a situation that comes as close as possible to clinical equipoise and uncertainty, such that one can genuinely ask, do these results represent a glass half empty or a glass half full result? Since the publication of Protocol 201, there have been other studies that have reported data on the relative rates of penetration aspiration on different liquid consistencies. And today I'd like to take you through 3 of those studies. The first is my current NIH-funded research looking at the physiology of swallowing across the range from thin to extremely thick liquids. And I'll share data with you from our healthy cohort, which included 76 adults ranging in age from 21 to 82. Then I will share similar data from a large industry-funded study known as the Sonar Study, which included more than 300 adults who were referred for video fluoroscopy due to suspected dysphagia. This sample included about 100 individuals with a history of stroke. However, most were beyond the acute stage. And finally, I will share some data from a more recent industry-funded study known as the Porsche Study, and I will specifically focus on the 192 participants in that sample who had a primary diagnosis of stroke, noting that this was a more acute sample than the stroke group in the Sonar Study, with an average time post-onset of 18 days. In all three studies, a similar protocol was used where participants took a series of comfortable sips of barium from a cup, starting with thin liquid and progressing to thicker consistencies, which were all prepared with Nestlé's xanthan gum thickener resource Thicken Up Clear. The moderately and extremely thick liquids were taken by teaspoon. And so we have data that enable us to look at the relative frequency of penetration aspiration by consistency. So let's start by looking at the thin liquid boluses in my recent study of 76 healthy adults. These data are updated from an earlier published result regarding the adults aged under 60 in this sample. Here we're looking at data for 226 thin boluses, of which 85% had penetration aspiration scale scores of 1, indicating absolutely no airway invasion. 11% showed scores of 2 with transient entry into the laryngeal vestibule followed by ejection. And the remaining 3.5% of scores were all penetration with scores of 3, 4, or 5, and absolutely no events of aspiration below the true vocal folds. When we look at these same data asking instead how many participants had a worst past score of 2, the answer was 14, or 18% of the sample, while the scores of 3, 4, or 5 were seen in only 7 people, or 9% of the participants in the study. On this slide, I have added in the other consistencies, and we're showing the percent of the boluses of each consistency where we saw penetration aspiration scale scores of 3 or higher, which we called unsafe. And here we're dealing with very small numbers of penetration aspiration overall, which becomes a challenge from a statistical power perspective. But at the bolus level, there were lower odds of unsafe swallows for the slightly, moderately, and extremely thick liquids compared to thin. Turning to the Sonar study, I want to first draw your attention to a really important finding that we saw across the 6 sips of thin liquid that were taken at the beginning of the protocol, namely that a person with dysphagia involving penetration aspiration is unlikely to show that problem on every swallow. This graph shows the percentage of participants who showed penetration aspiration scale scores of 3 or worse on each of those thin sips. Here we know that the average sip volume was about 12 milliliters. You can see that on the first bolus, 8% of the sample showed a problem, but 92% of the participants had safe swallows. When we move on to the second bolus, a new group of 7% showed their first occurrence of penetration aspiration, so that the total number of participants who had shown a problem had increased to 15%. On the third bolus, 3% more of the sample showed penetration aspiration for the first time. On the fourth bolus, that increased again, so the total had reached 22%, and so forth. We stopped the thin liquids after 6 boluses, so we don't know what would have happened if we had kept going. But these data do suggest that at least 4 boluses of thin liquid are needed to rule out penetration aspiration. And this means that our assessment protocols need to include several repeated sips if we want to be certain to classify swallowing safety accurately in our patients on thin liquids. When we look at the data regarding penetration aspiration on thin liquids in the Sonar study, we see that 92.8% of the boluses had scores of 1 or 2 and were considered safe. Scores of concern were seen in only 7.2% of the boluses, and these boluses came from just under 1/4 of the participants in the study, reminding us of the point made in the previous slide that across a series of repeated sips, individual participants showed penetration aspiration inconsistently. When we look at the number of participants who showed at least 1 penetration aspiration event by consistency, we see that significantly fewer participants had unsafe swallows on mildly thick compared to thin liquids, with further improvements with the even thicker liquids. The Porsche Trial intentionally recruited participants who were in more acute stages of illness than the Sonar study. So rather than the 7.2% frequency of unsafe boluses that we saw from 23% of the participants in Sonar, here among the participants with a primary diagnosis of stroke, 33.4% of the boluses, coming from 62% of those participants, were classified as unsafe. When we look at the number of participants from the stroke cohort who had at least one unsafe swallow by consistency, we see significant reductions in penetration aspiration with thicker liquids. So all three of these studies agree with the results of Protocol 201 in showing reduced penetration aspiration with thicker consistencies. There is one caveat that I want to mention, which may be a confounding factor in the results that we've shown, and that is bolus size. In all three studies that I've discussed, the liquids that were thin, slightly thick, or mildly thick were taken as natural sips from a cup. However, if you have ever tried to drink a moderately thick or extremely thick liquid from a cup, you will know that this is challenging because these liquids flow so slowly. So in all three studies, these thickest liquids were taken by teaspoon, with the consequence that the boluses were smaller, averaging about 5 to 6 milliliters. And this means that part of the explanation for the reduction in aspiration may be due to smaller bolus size. So we know that thicker liquids were effective in direct comparison to thin liquids within the same video fluoroscopy. But what do we know about the longer-term effects of this intervention, and specifically, do thickened liquids prevent pneumonia? Here, let's return to Protocol 201, where you may recall that there were two experiments. Experiment 2 involved random assignment of participants to one of the three interventions of interest, namely thin liquids swallowed using a chin-down posture, mildly thick liquids, or extremely thick liquids. And health status outcomes were monitored for a 3-month time frame. However, the authors had a dilemma. Among the 51% of participants in Experiment 1 who had shown a positive response, half of them, that is 25%, had actually shown a best response on one of those interventions, while the other half responded well to all three interventions. And the authors decided that random assignment to an intervention was only ethical for individuals who had shown equal responsiveness to all three interventions. So the individuals who had shown a best response were actually discharged from further observation, while those who responded either favorably or badly to all three interventions were carried forward into Experiment 2 and were assigned randomly to use one of the interventions for 3 months. This is a really important detail to understand about Protocol 201, because one might hypothesize on this basis that pneumonia might be more likely in those who continued to aspirate on all three interventions in Experiment 1, namely 2/3 of the participants who were carried forward into Experiment 2. But that is not what happened. Overall, in Experiment 2 of Protocol 201, there was only a 10% incidence of pneumonia over 3 months. Overall, there were similar rates of pneumonia, around that 10% mark, both in those assigned to thickened liquids and in those assigned to drinking thin liquids using a chin-down position. However, a closer look within those assigned to the thickened liquids shows two interesting findings. First, those assigned to the nectar or mildly thick liquids had about an 8% rate of pneumonia, that is slightly lower than we saw on the previous slide for the chin-down condition. And second, unexpectedly, those assigned to the honey or extremely thick liquids actually had a pneumonia rate of 15%, double that seen with the mildly thick liquids. The Protocol 201 is really the first study to point out that there can be negative outcomes associated with the use of thickened liquids. In addition to increased rates of pneumonia, those randomized to those extremely thick liquids also had higher rates of dehydration, hospitalization, and death. So how do we make sense of these results? There are a few key points to remember. First, 2/3 of the participants in Experiment 2 were those who had shown continued aspiration on all three interventions in Experiment 1. Given that, The 15% pneumonia rate in those assigned to the extremely thick liquids may actually be relatively low. Second, the data challenged the historical view that if some thickening is a good thing, then more thickening would be even better. The results suggest that overly thick liquids may be contraindicated in people who are prone to aspiration. My personal take-home message from this is that thickened liquids should not be recommended unless there has first been an assessment demonstrating that they are safe and effective. And herein lies the issue that I believe is the main basis behind the concerns raised in the recent articles by O'Keefe, Lippert, and Lazenby-Patterson. Namely, we have become too quick to recommend thickened liquids and texture-modified diets without first insisting on an assessment that shows that they are safe and effective. The other thing we need to remember is that Protocol 201 clearly shows that aspiration does not inevitably lead to pneumonia. Indeed, other studies suggest that pneumonia is most likely to develop in the context of a triple threat involving colonization of the oropharynx with bacteria that are respiratory pathogens, transportation of those pathogenic bacteria into the respiratory system via aspiration of food, liquid, or saliva, and an impaired immune response. Several studies suggest that dysphagia involving aspiration is not by itself sufficient to predict pneumonia. However, if a person with dysphagia involving aspiration also has frailty, reduced mobility, or difficulty with activities of daily living, including performing mouth care, then their risk for pneumonia increases. This is true both in stroke survivors and in other groups where dysphagia is common, including those living in long-term care facilities. And in all of these patient groups, we need to be clear that the presence of a feeding tube, which may be necessary in order to ensure adequate nutrition and hydration, does not reduce risk for pneumonia, but in fact is associated with increased risk. On balance then, given that we have seen that thickened liquids can be effective for limiting aspiration, it is also reasonable to suggest that they may play a role in limiting pneumonia risk, provided that they are recommended based on the results of a swallowing assessment. However, in addition to determining whether thickened liquids are effective for reducing penetration aspiration, it is also important to make sure that they are not contributing to increased pharyngeal residue, which can become a risk for subsequent aspiration. Several studies point to this as a possibility, and it's a question that I've been recently exploring in my own research on swallowing physiology. To do this, we perform pixel-based tracing in a freeware called ImageJ to produce precise measures of residue area from lateral view video fluoroscopic images. We compare the area of residue to an anatomical scalar, which is the squared length of the C2 to C4 vertebral spine, and the residue is expressed as a percentage of that area. Let me illustrate with this example. The yellow outlined residue in the vallecula takes up 2.7% of the C24 squared reference area shown by the white dashed square. The piriform sinus residue outlined in turquoise takes up 1.9% of that same reference area. And we can add those measures together for a representation of total pharyngeal residue. On comfortable sips of thin liquids, we have found that healthy people typically have residue measuring 1% or less of that C24 squared reference area. With sips of slightly and mildly thick liquids, we found greater residue with the mildly thick liquids, typically measuring up to 2% of the reference area. And on teaspoons of moderately thick and extremely thick liquid, we found that residue typically fell back down below that 1% threshold, except with the starch thickened moderately thick liquids. We've recently published an analysis of all the swallows in the Sonar dataset where we looked at the risk of penetration aspiration on swallows that took place in the context of residue that was already in the pharynx, either below or above that 1% threshold. When there was residue in the pharynx above 1% C24 squared, there was at least double the risk for penetration aspiration on the next swallow. We also used the Sonar Study data to look at how frequently residue above that 1% threshold occurred according to consistency. This graph shows the data for boluses that were smaller than 14.8 milliliters in size, and you can see that there was no pattern of increased residue with increased thickness using the xanthan gum thickened liquids in that study. However, for larger boluses of thin and mildly thick liquid that were above that 14.8 milliliter size, we did see increased residue with the mildly thick liquids. So here again, it's important to consider bolus size as well as thickness, and to remember that the combination of a large bolus and a thick bolus appears to be likely to leave greater residue. So before we wrap up with a discussion of best practice when recommending texture modification, I want to briefly speak about alternatives to thickened liquids that might be considered. I would argue that it is all very well to be critical of the limited evidence showing benefit with thickened liquids for managing aspiration and pneumonia risk, but unless we have evidence that a different intervention is as effective or better, we risk throwing the proverbial baby out with the bathwater. Critics of thickened liquids mainly point to two alternative approaches in the literature. The first is the so-called free water protocol developed at the Frazier Rehab Institute in Louisville, Kentucky. There are several variations on this approach, but most commonly the protocol allows people with dysphagia to drink regular water in between meals, while thickened liquids are provided with meals. Many of these protocols also emphasize good oral hygiene. And all of the studies in the literature suffer from power issues with small sample sizes, but converging results do suggest that medically stable stroke survivors with dysphagia who are either in or beyond the rehabilitation phase tolerate this intervention well without developing respiratory infections. However, complications including pneumonia have been reported with the free water protocol when it is used in an acute care setting, particularly with frail seniors with cognitive impairment. The second alternative espoused by critics of texture modification is the use of sensory enhancement techniques to improve swallowing. Here, the general premise is that the sensory attributes that are likely to excite trigeminal nerve or taste receptors will provide enhanced sensory input to brain centers involved in swallow regulation, thereby eliciting swallows that are more timely or stronger. The available evidence comes predominantly from work in healthy adults, and the attributes of extreme sourness and carbonation do show some promise as to stimuli that excite TRPV1 receptors, such as the capsaicin found in hot chili peppers. This research, in my opinion, should still be considered exploratory and not ready for wide-scale implementation. Additionally, there are obvious challenges to overcome when considering both the palatability of these stimuli and the questionable feasibility of suggesting that all food or liquid in a person's diet needs to be laced with these stimulatory attributes. And so we're faced with a current state of evidence where several studies concur that thickened liquids do reduce penetration aspiration compared to thin liquids, but it is unclear whether thickened liquids help to prevent pneumonia. Given the multiple factors that place a patient at risk for pneumonia, I would actually argue that it is unreasonable to expect thickened liquids to be effective in limiting pneumonia unless the other risk factors are also addressed. We currently have insufficient evidence that there are alternatives to thickened liquids that are both effective and feasible. To conclude, let me suggest some best practice recommendations regarding texture modification as an intervention for people with dysphagia. First, it is critical to remember that thickened liquids may not be suitable for all patients with dysphagia involving penetration aspiration. Here, I strongly agree with the sentiments expressed by O'Keefe, Lippert, and Lazenby-Patterson that thickened liquids are currently overused. This intervention, like others, should be based on the findings of a properly performed assessment. We must also challenge the pervasive view that aspiration inevitably leads to pneumonia. We should consider other factors when determining patient risk. On the other hand, it is cavalier and dangerous to adopt the perspective that thickened liquids are entirely unnecessary. Although there is insufficient evidence to confirm that they prevent pneumonia, this does not mean they have no effect. They remain one possible and feasible intervention for limiting aspiration as a component of pneumonia risk. However, when we do recommend thickened liquids, we should remember that there may be such a thing as too thick and must be certain that we understand the impact of thickened liquids on swallowing efficiency and residue. Personally, I think that we should try to determine the thinnest possible thickened liquid that demonstrates effectiveness for our patients. And finally, it is crucial to remember that swallowing function can change over time in a patient, both for better or for worse. This is especially true in stroke survivors, many of whom enjoy good recovery of function by 3 months post-onset. And here we should advocate for access to follow-up assessments and regular opportunities to reevaluate the need for continued diet texture restrictions. With that, I thank Nestle once again for the opportunity to speak in this webinar and would be happy to take some questions.
Hello, everybody. This is Katrina Steele from Canada, and thank you for joining the webinar today. We do have plenty of time for questions. And there have been a couple that have come in already, but please do feel free to use the Q&A button at the bottom of your screen to suggest questions that you'd like me to answer. I'll start with the questions that have come in already. The first one from Rachel in Liverpool asked, what do I mean by swallowing assessment? Do I mean a bedside swallowing assessment by a speech-language pathologist, or an instrumental objective assessment like a video fluoroscopy or a FEES exam? So I think this is obviously a challenging question to answer, because I appreciate that many clinicians don't have easy access to instrumental assessments, at least not on a regular basis. And right now in COVID, that's even more true. And so I think we need to approach this pragmatically. I definitely believe strongly that where instrumental assessments are available, that they give more accurate information regarding penetration aspiration and also regarding residue than a bedside assessment. But I do think there is room for a careful and comprehensive consideration of everything you know about the patient, including their history, that will help you decide how crucial it is to obtain an instrumental assessment. And really here I'm talking about the risk that the clinical signs are confusing. So things like silent aspiration or unreliable reporting of residue. If you feel as a clinician that you can't be certain about those questions, then those are particularly good cases to take to an instrumental exam. And obviously, if you're also thinking of planning behavioral type interventions and you want to target physiology, then I feel quite strongly that you need those instrumental exams. So I think there's room for careful, methodical, comprehensive clinical bedside assessment to guide choices around diet texture, but it is second best, if you will. There was also a question, let's see if I go back up here, from Leanne, who asked, is it best to start with level 1 slightly thick, especially when you can't get to do an assessment due to COVID restrictions? So I'm not quite sure whether Leanne is asking about the use of level 1 slightly thick liquids as an intervention and a sort of conservative, cautious choice to recommend that, or a question about what texture do you start with in an assessment. I'll start with the assessment side and say that my opinion is very strongly that I want to build my assessment to answer my key questions as efficiently and quickly as possible. And that I personally prefer to start with thin liquids and to use water as that thin liquid, precisely because it is the most likely to reveal a problem with swallowing safety. And so in an assessment, I would always start with thin. I think there would be extremely few exceptions to that. In terms of then going thicker, I think that there is at the moment insufficient evidence regarding the effectiveness of level 1 slightly thick liquids because they're quite new. That's coming, and I am hopeful that over time that will turn out to be an effective level of thickening because it's more palatable. And so in terms of treatment and whether you would start with level 1, I think that would have to depend on your observations, either clinical or instrumental, to decide whether you thought that was an effective level. I'm going to go back up and read the questions. So here's a challenging one from I can't see the name. So how would you recommend balancing the risk of being nil by mouth versus being on potentially unsafe oral intake in the acute care setting? This is a challenging question. I think it needs to take into consideration what you know about the health status of the patient, their major diagnoses, their pre-morbid conditions and risk, and particularly situations around their respiratory status. So if you feel they have a more fragile respiratory system or are unable to look after their own mouth care, then those would be particularly risky situations. I think that the decision needs to be guided not only by clinical observations, but by discussion with the patient and the family. And I think that there are circumstances in which a decision can be arrived at collectively to trial some oral intake. I would again here usually start with small sips of water or ice chips in an observational way, and then gradually progress beyond that if the patient appears to be tolerating it. All right, let me see if I can manage my screen here just a little bit better. All right, is there evidence that aspirated thin water is safer than thickened water, or indeed safer than strong, clear, I imagine, thin alcohol? This is a challenging question. I think that there is emerging evidence that aspirating thickened liquids, whether that be thickened water or other thickened substances, is not a great situation and does involve risk both of respiratory infection and of more complicated hospital stays. So that evidence goes back, of course, to Protocol 201, where I highlighted that with the very extremely thick liquids that there was a higher rate of pneumonia, remembering, though, that many of those patients were aspirating those thickened liquids. And just in the last year or two, there have been several studies published using animal models, rats and rabbits, where thickened material or thin material has been actually directly delivered to the lungs of these experimental animals. And it's the sort of overriding finding is that the thickened substances are more toxic to the lungs than thin water. I can't comment on whether aspirating alcohol is safe or not. I'm not aware of any clear evidence in that regard. All right. Yes, so a question here from Leslie, and a couple of questions that came in advance of actually asking whether the findings and the interventions that I've suggested can be extrapolated to the pediatric population. So I'm not a pediatric clinician. It hasn't formed a great deal of my caseload, but I'll take a stab here and share just a couple of things that I know. So to my knowledge, there hasn't been a study that has looked at the effectiveness or the safety of thickened liquids as an intervention for aspiration in children with dysphagia. I'm aware that there is some work going on in this regard, led by people like Caitlin McGrattan in Minnesota and Memory Gosa in Alabama. And here there is an anecdotal report from clinicians for many years that using a slightly thick liquid can be clinically effective and without over challenging the efficiency of swallowing particularly for bottle feeding babies, because it's still thin enough to easily express from the nipple of a bottle. So that's anecdotal evidence. I know there are some studies going on looking at this. There are, of course, some other things to be aware of here. I think there's some concern that if you don't introduce children to thin liquids, that there could be a critical period. And if they don't learn to master swallowing with thin liquids in that critical period, that there could be a sort of disuse or lack of learning that could impact them in the long term. And the other thing, of course, to report is that there is really no good thickener to use with infants in particular, that there are a number of concerns about safety. There was, unfortunately, a serious adverse event with Simply Thick in the United States, which is a xanthan-based product, where there were some children who developed necrotizing enterocolitis on that product, which later was thought to be largely due to contamination at the packing plant rather than specifically the product. But there, I think it's safe to say that there's real concern in the area of managing infants with aspiration, that we really don't have a good and ideal thickener to use with that group. All right, now let me see. Does the type of thickener that you use influence the risk of pneumonia? This is coming from Jana. And so, Jana, I'm not familiar with any research that has definitively answered this question. Again, at least not in humans. So the animal work that I mentioned a few minutes ago in rats and rabbits, I believe that there has been a look at xanthan gum thickened liquids being delivered directly to the lungs versus starch thickened liquids being delivered directly to the lungs, and that there was greater damage, tissue damage, to the lungs with the starch versus the gum. But I think those are very preliminary findings. And I do want to keep reiterating here that in all of these studies, they have sort of enforced or made it mandatory that these thickened liquids are aspirated. And to remind all of you that the goal of using thickened liquids is to limit and avoid aspiration. So if you're working with a patient where thickened liquids appear to be effective for reducing aspiration, then these questions of whether the person will develop pneumonia, the ones that have looked at people who aspirate those liquids don't really apply. All right, let's see. Okay. A question from Katrina McConkey. Why was a chin tuck used in the study for thin drinks but not for levels 2 or 4 for the mildly and extremely thick liquids? I think that this is going back to Protocol 201. The idea of using a chin tuck was that it would be an intervention that wouldn't involve thickened liquids and could be applied without requiring thickener. So that was simply the decision of the investigators there. I'm seeing quite a lot of questions about the specific evidence applicable to particular populations. So just as people asked about pediatrics, there's a question here about, is there evidence that's applicable for people with mental retardation, so developmental disabilities and intellectual disabilities. And I am not aware of any research that has been specifically done looking at the effectiveness of thickened liquids for reducing aspiration in that population. And I think this is one of those situations that's common in our dysphagia world, that the studies that need to be done with quite large sample sizes. And often we find ourselves trying to extrapolate from, for example, a group of people who've had dysphagia following stroke to another population. And sometimes that extrapolation is worthwhile, and other times we have to recognize that there might be real questions. I can say in my own experience and knowledge of people with developmental disability and sort of very long-term dysphagia, that it does appear to be true that many of these individuals cope with aspiration for quite some time. I've certainly worked with patients myself where we're certain that they're aspirating and they seem to defy the rules, if you will, that they enjoy what they're eating and drinking. We're very concerned that they're aspirating, but they don't seem to suffer a consequence. What I will say is that this group then, as they age, they tend to present like older people who may decompensate more easily. So then all of a sudden something may come along that seems unrelated, like a urinary tract infection or a cold or a flu, and that is just enough to tip them over the balance from coping to no longer coping. And so they decompensate so that their aspiration then becomes something that their bodies can't handle. And so a very common cause of death in that population is, in fact, aspiration pneumonia. And so I think the same findings that we see in the elderly population with those concerns about decompensation apply in the developmental disability population. Let's see. There's a couple of questions here about the free water protocol. First of all, am I aware of more studies being done? And secondly, regarding the occurrence of pneumonia when using the free water protocol, is there evidence about whether this is as frequent as with other interventions? So I'm actually not currently aware of a formal study ongoing of the free water protocol. I think this is quite a difficult study to mount because many of us are inclined to recommend water protocols when we think that they might be tolerated. And so having a good comparison group is hard to achieve. And that's also one of the reasons why the available literature has had very small sample sizes. I am not aware of a study that has directly compared either outcomes or risks with the free water protocol to other interventions, thickened or postural. And I think this raises a good question for our field in that good randomized control trials try to achieve clean group conditions where people are using one intervention versus another intervention. And we need to recognize that that doesn't really fit with clinical reality, where we often will recommend more than one intervention that we think is applicable for a patient. So I think we do need more research moving forward, more case studies where people use similar methods to measure outcomes in these situations where we've chosen well-intended and well-justified interventions for a particular patient's pathophysiology, and we learn over time about combined interventions. Certainly, I think it would be quite likely that if you're recommending free water, that you might also be recommending safe swallowing strategies with that water at the same time. So it's not really an intervention that has been studied in and of itself, and certainly most of the studies have also included attention to mouth care. All right, so here's a challenging question from Leo. Given that aspiration is not an independent predictor of pneumonia, what rationale can we give to patients and other medical professionals for interventions to reduce aspiration? Well, I think that, Leo, even though aspiration isn't an independent predictor of pneumonia, there is pretty clear evidence in groups like stroke that in people who have verified dysphagia or verified aspiration, that the risk of pneumonia is dramatically higher. And so I was just looking recently at data from Germany that showed this point in new stroke patients. So I think that we can't rule out aspiration as an important and necessary component in pneumonia pathogenesis. And so I do believe that where we identify aspiration as something that is going on, we have a responsibility to consider interventions that will limit it, as well as managing the other risks for pneumonia. And one of those interventions might be thickened liquids in a particular patient. All right, moving down. Would I always recommend trialing a chin tuck with thin fluids before trialing thickened liquids if a patient coughs on thin on a bedside swallowing assessment? This is a great question from Rianne. Well, I think that no, I wouldn't always recommend trialing a chin tuck at bedside. And this is really because I'm also aware that there are cases in which a chin tuck can be contraindicated. And the things I'm concerned about here are whether there's residue. There's evidence to suggest that if you tuck your chin with residue already in the pharynx, that the risk of aspirating on the, that residue goes up. So I'd want to be trying to determine clinically the balance between observations of unsafe swallows with observations of possibly inefficient swallows. So if the patient seems to be needing to take multiple swallows per bolus as a sign of possible inefficiency, or if they tell you that they feel residue, then I would be cautious about going straight to a chin tuck in that patient. And I'd be trying to think about other techniques. Of course, if you have instrumental swallowing assessment available, then you can be much more confident about your observations about whether a chin tuck might be indicated and then evaluating its effectiveness. All right, lots of questions that have been coming in here. Let's see. Benedict has also asked about the pediatric population and research. I do know that there is some research ongoing. There's always a need for more. So people like Pamela Dodrell, Maureen Lefton-Greif, Memory Gosa, and Caitlin McGrattan are really leading that in North America. And I'm sure that there are people engaged in that also in Europe. Here's a question from Andy asking whether I would still start with thin if staff or past assessments had shown coughing on a thin liquid after the swallow. This sometimes appears to skew or make it difficult to proceed effectively because the patient continues to cough or throat clear. So this is a great question, Andy, and I think there's always a risk that whatever liquid you start with, whether that be thin or thick, that the situation that evolves on that first bolus that you present can contaminate the situation for every swallow after that. So it's true if a patient has a really serious aspiration event with a lot of coughing, that they may be uncomfortable and it may not be wise to continue right away onto additional boluses. So that's one kind of contamination of the assessment scenario. The other, though, I think, which is much more common, is that if people start with a thickened liquid, first of all, you haven't answered the priority question about safety, and you've then quite possibly may have residue in the pharynx. And our recent research really does clearly show that if there's material already in the pharynx above that 1% threshold of the C24 squared reference area, that there is double the risk of aspirating on the next swallow. And that's true if the person is just doing a clearing swallow of residue, but it's also true and more true if they're introducing a new bolus on top of that residue. So if you have residue in the pharynx and then want to go back and evaluate thin, you're not really getting a clean picture of the risk within by itself. I think there's a counter argument to be made there that normal mealtime eating may well involve these situations where there's already material in the pharynx. And so I think actually I would start with thin still, but if there's residue that evolves across the study, then it's a good idea to come back and test thin again later to see whether things have changed. All right. That question, I'm just going down the long list here. A question from Yana again, that I talked about the 3 elements that can lead to pneumonia, and is the volume of aspirated material important in identifying the pneumonia risk? I actually don't know the answer to this question, Yana. I'm not aware of a study that gives us that particular answer. I do think that clinically we do see variation in the tolerance of aspirations. So as I mentioned before, for example, in the developmental disabilities population, you may see people who are aspirating quite a lot and don't seem to get sick, whereas there might be another patient who aspirates a tiny, tiny amount, and that appears to be too much for them. So I think this is where the other factors that are relevant for pneumonia come into play. In terms of the person's ability to tolerate that, and things like how mobile they are and what their respiratory status is in the first place come into play. I will say in the free water literature, one of the studies that showed complications was a study that looked at free water in stroke patients in acute care and also in older patients with cognitive impairment admitted to the same acute care site. And the only occurrences of pneumonia in that study were in the older patients with cognitive impairment who were less able to sort of do their own self-care. All right. What if the alternatives of thick liquids did not go well with the patient? Should you go with the least thickened liquid to reduce the chance of residue and pneumonia? So this is a great question as well. I think that it's important that we remember that we have other interventions in our toolbox. We should be doing more than just looking for the right consistencies to recommend in somebody's diet. And considering things like compensatory techniques at the same time, and also therapy, ideally, to rehabilitate the swallow. So if I would feel, I think, uncomfortable in general recommending a diet texture that I had observed to be either unsafe for a patient or one where there was extreme inefficiency for a patient. So I'd be trying to find diet textures that I think don't really stress the impairment of safety and of efficiency, and finding that sweet spot, if you will. But if you're really struggling to find any consistency that is effective for a patient, that might be a case where some very limited oral intake of the safest possible consistency is used initially, along with maneuvers and interventions that you think and that you've evaluated that are helpful. And over time, presuming that this is a patient who's on a trajectory of improvement rather than deterioration, there may be the ability to expand the diet consistencies. All right. Is there any evidence of the ability of an individual to clear modified fluid if aspirated and of thicker consistency if they have a weaker cough strength? So this question from Warren is an important question. If you were to ask Dr. Logeman, if she was still here, to explain to us why she thought the people on the extremely thick liquid were more likely to develop pneumonia, her interpretation was that they had aspirated that thickened liquid, and it would, because it was thick, it would be that much harder to clear from the lungs. And this is indeed also where certain thickeners may be harder for the lungs to absorb the fluid over time. So yes, I think if you have the combination of aspiration, particularly on thicker consistencies, and somebody with reduced cough function, then you've got a really bad combination, and I would be very, very careful there. This is a great place for collaboration with physical therapy and for attention to the cough to see if a more productive cough can be trained, and to look at chest physio for clearing any material that is aspirated, but this would be a very high-risk population. Ali from KU Leuven, hi Ali, is asking whether I think the application of thickeners needs continuous assessment, and how often do I think this assessment should be implemented. So yes, I do think that we do not provide enough reassessment of texture modification when we've recommended it. I'm actually very concerned here in my own home neighborhood in Canada that we recommend diet texture modification, we discharge people, and then we don't provide enough opportunity for reassessment. So I think particularly if you're working with people who are expected to get better, that reevaluation of the need for thickeners should be planned after it has been recommended. I think the clinical signs should be taken into consideration. I think definitely by 3 months there should be a reevaluation, but perhaps sooner depending on the caseload. And it's also true that if somebody has a degenerative condition, that I think the need for texture modification needs to be regularly revisited and tweaked and refined so that the patient has the optimum diet consistency. Of course, it may not be possible to provide regular, repeated radiographic assessments to people, so we're going to need to be smart and go in with very clear questions in those reassessments and try to get the answers to our questions as efficiently as possible. I just looked at the clock and saw that we're slightly over, so I'm going to take one more question here. Before I do that, I've been asked to remind you that you will receive an email containing a feedback survey after today's webinar, to encourage you to complete that and send it back, and to say that there will be a recording of today's session available both on the Nestle UK's website and the Nestle nutrition website, and that there also, for the UK participants, is a downloadable continuous professional development reflection form if you want to keep a record of your observations from today's session. Let me just see. see. Here's a good one, and we'll make this the final question for today. This comes from Lori, Eastern Health. That might be Newfoundland, so hi Newfoundland, if that's true. Can I speak to the issue with increasing risk of dehydration with thickened liquids versus the risk of aspiration with thin? So there is some evidence to suggest that dehydration is an increased risk when people are on thickened liquids. The explanation for that increased risk is not that the liquids themselves are so thick that the fluid, the available sort of water in the fluid can't be taken up by the body, but rather that people drink less when they're provided with thickened liquids. And this is probably more true the thicker the liquid is. And so there are two hypotheses why people drink less. One is that they become full quicker, and this is, I think, a higher risk with starch thickened liquids. There's more thickener that goes in to those thickened liquids. So if you have a very thick starch thickened liquid, then people will start to feel full and may not drink as much as they would otherwise. And the other risk, of course, is that people don't like thickened liquids and will consume less because of the palatability concerns. So this is, again, where trying to find the least thick liquid that has clinical benefit is the best practice recommendation. And I think it's important to monitor the risk of dehydration initially in these patients to make sure that they are consuming enough. And this, I think, again, just to highlight the need for the multidisciplinary team and for collaboration, it is important to flag the potential for dehydration with people like the dietitian and the doctor on the team to monitor for any risks. I have seen some patients where fluid intake is a really critical piece of their health management and where thickened liquids have needed to be very carefully managed because of that. So we've come to the end of our time. I thank you for your attention. I really hope this has been helpful. I did provide my lab website email on the final slide, which is on the handout as well. And if there are questions I wasn't able to get to, please do feel free to send them to me by email. Thank you so much.